Okay, so I think we can go. Again, everyone, welcome. This is Mariangela Pellegrini. I'm the Educational Patient Program Manager for the ERN-EuroBloodNet European Reference Network for Rare Hematological Disease. So welcome. As you may know, this is an educational program named Topic on Focus on Constitutional Thrombocytopenia. It is an accredited European online educational program. The target is health professional. Indeed, it is accredited, and it hasn't been created in partnership with the French Reference Center for Inherited Platelet Disorder and the Filière MHEMO, the French Constitutional Bleeding Disorder Network. And this program consists indeed of a cycle of 15 webinars that are focused on this clinical domain, and has been developed in collaboration with 3 experts. So Professor Marie-Christine Alessi, Dr. Paul Saultier from Assistance Publique-Hôpitaux de Marseille. They are member also of the ERN, and Dr. Mathieu Fiore from Bordeaux. So before entering into the topic of today, because as you can imagine, the main objective of the program is really to disseminate up-to-date knowledge among the health professional groups on this field of constitutional thrombocytopenia. So before arriving to that, I would like to share with you some home rules. So as you can see, this webinar is recorded. So if you don't feel comfortable with that, you can switch off your camera or notify, tweet, change your name. So please feel comfortable. And then this webinar will be recorded, and the video will be integrated in the e-learning environment. Then your microphone will be muted along all the presentation. At the end of the presentation, we have the Q&A session. So you have 2 possibilities. You can write your question in the chat during the presentation and they will be addressed at the end. Or you can, at the end, raise your hand if you prefer to take the floor and share your comment, questions, feedback, whatever you prefer with the speaker. Finally, each session, so each webinar of this program is accredited with 1 continuing medical education point of the European Body of Accreditation in Hematology. At the end of the program, you will receive the instructor for getting the credit. And so we will tell you about how many credits you can take. You can claim according to how many sessions, in which session you have participated. So don't worry, we will provide all those information. So finally, we arrive at today's lecture. I hope to pronounce it properly. So we are going to, please correct me then, Professor Pasquet, if I'm misspelling the title. So today we are talking about Amegakaryocytic thrombocytopenia with or without skeletal abnormalities. With us, the Professor Marlène Pasquet, who is Pediatric Hematology and Immunology, Head of the Clinical Research Unit in Pediatric Hematology, Immunology and Oncology Department at Toulouse University Hospital in France. She's involved in the Platelet Reference Center as pediatrician, together with Dr. Sophie Wazan. And so I'm very honored to pass the floor to you, Professor Pasquet. Thank you very much.
Thank you very much, Mariangela. Can you hear me and see my slides? It is okay, I will start. So
yes, perfect, thank you.
So thank you for the invitation today. I will talk about congenital Amegakaryocytic thrombocytopenia, and as you just said, it's very, very difficult to pronounce. So I will say for the next slides in my presentation, it is a so-called disease CAMT, so I will use CAMT. And in the original title, it was with or without skeletal abnormalities. So in fact, I won't keep all the as a secret, all of this, because in CAMT it is without skeletal abnormalities. So I will go through a little bit, but there is no skeletal abnormalities. So as you introduced me, I am a pediatrician and hematologist, and I am working with Sophie Voisin in the reference center in platelets in Toulouse. So no, yes, I have nothing to declare. So at the end, you could just ask me some question, and if you could mute your microphone, could be good. So the objective of a webinar is to recognize the clinical and biologic scenes of CAMT in the background of thrombocytopenia, because as I can see, many people here are involved in congenital thrombocytopenia, as CAMT is quite a different disease. I will go through and how to evoke CAMT as a differential diagnosis of other thrombocytopenic disorder and some genetic issues, and I will finish by the basic of CAMT treatment. So starting with the definition, what we can say is CAMT is a very rare, what we call inherited bone marrow failure syndrome, and I will explain it later, and is characterized by an isolated and usually severe decrease in the number of plaquettes and megakaryocytes in the bone marrow. So this happens usually during the first years of life, so usually it is a matter of pediatrician, and that developed later on into bone marrow failure with pancytopenia in childhood, affecting all marrow lineage. So usually it is associated with implementation, and I will explain it later and so on. So there is few cases in the literature, usually said less than 100. In fact, it is not a disease well described. There's not a lot of literature about that. And there are some ethnic groups involved, and I just wrote a few of them because it is a homozygous German disease, so it could be a kind of consanguinity. So it's difficult to know the exact number of people, and it is a point I will go through in my presentation. So coming to history, the story started in 1999 with the first case of neonatal thrombocytopenia, and the people that described megakaryocyte morphological abnormalities, and then 20 years later came the description of inherited bone marrow failure, or IBMF, with congenital hypoplastic thrombocytopenia. It was the term so called. And then in the 60s, Korn and Hall, they described the TAR syndrome. I won't explain it in details today. It's not the topic of the call. But in TAR syndrome, the difference is bilateral radius aplasia associated with thrombocytopenia, and usually spontaneous recovery of hematologic syndrome when the children they grow. So then in the 1974, the author they separate of the IBMF into Fanconi subtypes and Amegakaryocytic subtypes, type 3 and type 4. And then the first defective response to THPO and hyperexpression of MPL in CAMT patient was described in 1997, and the CMPL deleterious mutation were identified by Hihara in 1999 as a genetic cause of CAMT. So it was not so old. And to the end, the Cal first described the THPO mutation, which could be associated with CAMT, and I will detail it later. And he described how this kind of mutation and the MPL mutation could be differentiated from other IBMF. We have to rule out when we diagnose a CAMT, like Fanconi anemia, dyskeratosis congenita, citrus, and MECOM-associated syndrome. So which are the warning signs in CAMT? It could have a broad clinical spectrum. So in case of a familial history, it is easy. If not, the first sign could be a very profound neonatal thrombocytopenia, but sometimes could be missed. And you can see thrombocytopenia in children with normal platelet volume. And sometimes you can diagnose it as pancytopenia or aplastic anemia. So you should be aware of that. In the literature at the beginning, there are some associated signs, but in fact, there are not a lot. So we found no skeletal abnormalities, we found no cardiovascular, no genital or urinary malformation, but you can find in some description Vermeer cerebral hyperplasia or other abnormalities or malformation of the microglia, and you can have some strabism and nystagmism, and it is most likely due to intracranial hemorrhage or consequence. So I don't know what happened. Is it a circle? Oh, thank you. Coming with a case, I have two cases I would like to share with you. Rose is a case we had in clinics, and she presented birth with neonatal thrombocytopenia from non-consanguineous parents. The mother had 2 miscarriages before, and she has a very profound thrombocytopenia. And what was important is in clinic, she has no hemorrhagic sins, so we were not really afraid of that, and she has a discrete foot lymphedema who led us to another IBMF. So at the beginning it was a bit tricky, and we tried IgIV. We showed small efficacy and platelets better efficacy, and what we saw during the first year is that we could see relapse of thrombocytopenia during infectious episodes. And which signs are important is the profound isolated thrombocytopenia and the response to the bad response to HIV. The thing that it happened at birth, and the platelets show better efficacy. So we had 2 other siblings, Nathan and Agathe. We diagnosed them with thrombocytopenia from infancy, not in a neonatal disease. And at the time we saw them, it was 8 and 6 years old. Nathan was polysymptomatic with only epistaxis. He underwent tonsillectomy and a transfusion of platelets with no bleeding. And the platelets were moderately low with normal volume, and neutrophil hemoglobins were in normal range. And Agathe has nearly the same clinical feature with more platelets and the normal neutrophils and hemoglobin, and she also underwent inguinal hernia surgery and the transfusion with no bleeding. So these ones are less symptomatic, and the disease appear less earlier. So these 4 signs could be just to keep in mind, but not specific from CAMT. So as these 2 examples, what we can see from the beginning is that there is a great heterogeneity of clinical courses. This is a review from 56 patients with CAMT-MPL, but not a lot of review and patient reported. This is one of the biggest ones. And the authors I pointed out that the most severe clinical problems were intracranial bleeding, and sometimes could be pre or perinatally. So we need to be aware of that, and resulting in long-term consequences. And some authors, they have identified that there is a functional deficit in neonatal platelets with a decrease in plateletin expression and reduced platelet activation and secretion. So the second most severe clinical problem is the development of aplastic anemia in nearly all patients except 1 in this study, and there is not a lot described in the literature as adult. So it could be a major problem. And in this review, they pointed out that thrombocytopenia was not detected at birth in a quarter of patients. So if you don't detect thrombocytopenia at birth, it doesn't mean it's not a CAMT. And they also describe a rate of non-hematological abnormalities a little bit higher, as I explained just before, from head region and mostly consequences of intracranial bleeding, sometimes prenatally. So how to diagnose a CAMT in this situation? So this is an old review, but it summarizes more or less what we have to do as clinicians. So be aware and keep in mind that CAMT is always an exclusion diagnosis. So what is mandatory is severe thrombocytopenia from birth, but sometimes, as I explained before, you don't have. And you should perform bone marrow aspiration to see if there is a reduced or absent megakaryocytes in the bone marrow, which is a good sign of CAMT. And the platelets, they have normal size, and you should exclude some acute form of thrombocytopenia if you diagnose it in an older patient, and exclude over IBMF. I will come back in a minute. Patients have no skeletal abnormalities. Usually in the bone marrow, you have a normal cytogenetic analysis. Sometimes you can see when a CAMT evolves in most older patients, some deletions or some chromosomal alterations such as monosomy 7 or 38. And then you go to MPL mutation analysis, which usually gives the clue and the diagnosis. So you can have on the right side of my slide some other clinical parameters, but they are not really informative except the highly elevated THPO serum level, which is really consistent with count. Sometimes you can have 10 to 50-fold elevated THPO in CAMT MPL, so this is important. And you can detect MPL on platelet surface and flow cytometry, but you need to have a good lab and good antibodies to perform that. So as I explained, CAMT is an exclusion diagnosis. So first of all, you need to rule out and to exclude the other IBMS syndromes, such as Fanconi anemia with chromosome breakage, such as dyskeratosis congenita with telomere length, and such as STAR, and you did some forearm X-ray. Once you have excluded the other IBMF, you can go to CAMT, and in fact, CAMT is still an ambiguous term, which can cover different syndromes. So there is a suggested nomenclature in the last review by the team, the German team really involved in CAMT, and that suggested that CAMT is the disease I explained and I gave definition at the beginning, and they separate CAMT into CAMT MPL, which is the most common CAMT with mutation of MPL gene, and they separate it with CAMT THPO, which is very rare, and it is dedicated to mutation in THPO, but more or less it is the same phenotype. You have to exclude some citrus. Citrus can be related to OXI11 gene or MECOM gene, and citrus is the same disease with Amegakaryocytic thrombocytopenia, but you find some radioulnar synostosis in this condition, so you need to perform some X-ray to exclude this condition. And you can have also what we call the MECOM-associated syndrome. It is like an IBMF with bone marrow failure, but you can find skeletal abnormalities, cardiac and renal abnormalities, hearing loss, and kind of immune deficiency with base cell deficiency. And this is associated in various degrees. Not all patients have all conditions, and it is associated with MECOM mutation. So one excluded all these conditions. We go back to CAMT, and usually in the literature you see two different types, type 1 and type 2. This is related to clinics and genetics. So type 1 is moderate to severe bleeding when platelets are usually below 50 since birth, with a rapid progression, usually before 2 years old, to pancytopenia, which reveals sideroblastic anemia. And usually this is associated with MPL loss of mutation function. CAMT2 is a moderate form with increasing plaquettes, sometimes during infectious disease, with variable clinical course, and some patients they get older, and it is associated with MPL residual or what we call alter activity. So the first description of genetics came in 1999, as I explained at the beginning in the short story. It was a girl, 10 years old, with thrombocytopenia since birth. She had the vehement cerebral hypoplasia. I showed you before that this could be associated, progressive pancytopenia. She has elevated THPO, and in fact, they discovered that CMPL, the receptor, was not detected in PBMC by RT-PCR. So why was it absent? They explain it by mutation, and they say that they postulate that there is a truncated protein with rapid turnover, and less HSC progenitor with this kind of MPL. It was a third description of mutation associated with CAMT. So what we know now from CAMT is that most often it is mutation in MPL gene, which then code the thrombopoietin receptor CMPL. And this receptor is expressed on HSCs and megakaryocytes. And as you can see on the right side of the cartoon, this activates some JAK-STAT pathway, like kinase pathway, and increase platelet production. It is a recessive transmission, and usually when you have a mutation in the CMPL, the TPO binding is impaired, and it doesn't stimulate the megakaryocyte development. So there is, in the last review, a very good overview of the kind of mutation you can find. On the left side, you have the transcript, on the right side, the protein. So what we can see from the beginning and the top, you have 12 coding exons. There is quite a hotspot on the 5 first exon in the cytokine homology domain 1, and this gather 80% of the mutation. The mutation could be or homozygous. In this series, it was most homozygous, and some patients that are compound heterozygous mutation also. So the most frequent mutation were missense mutation, which were found in 35 patients. You have also nonsense and Frenchish mutation, which are predicted to be loss of function, and some splice mutation, which could be some kind of loss of function or residual activity mutation. So the mutation with the less severe phenotype are marked in green color, and they separate like a kind of genotype-phenotype correlation. So coming to that, it's not so easy to have a genotype-phenotype correlation in this disease. We have some emerging information in the last cohort published. So the classical dichotomy is CAMP1, complete loss of function of the CMPL receptor, severe thrombocytopenia, and CAMP2, and associated, to loss of function mutation. And CAMP2, it is missense and some splice mutation with moderate phenotype. This is easy to remember. And you have also what the author tried to correlate is a CD110 expression on hematopoietic progenitor. And you can see on the right part of the cartoon that's a loss of function mutation. They have a lower expression than the missense mutation. So what they could correlate also in their cohort is that the cause of thrombocytopenia is linked to the type of mutation, while the time course of pancytopenia is not. Because maybe there are some kind of additional stress in HSCs, which could be linked to the infection the child will have during infancy, and the appearance of pancytopenia and bone marrow failure is not the same in all patients with the same mutation at the beginning. So we have also should have a small group of CAMP2 without pancytopenia. So this should exist, and a wide and wide strategy could be done as we did with Nata and Agatha at present time before BMT. So this should be kept in mind, even if it is not a lot of patients in natural history. And they found no relationship between the type of mutation and the kind of bleeding, moderate or severe. So coming to the pathology of thrombocytopenia and pancytopenia in this condition, there is a very interesting defect of HSC. It was demonstrated at the beginning by a reduction in CM2MK, but also in CM2 GM and E in the total bone marrow. We could detect VMPL by flow cytometry, but we need some specific antibodies, and we can see there is a diminution, the absence of VMPL detection. The Western blotting is usually not very helpful. It is complex, difficult, and we need a lot of plaquettes. So in patients with thrombocytopenia, it is sometimes difficult. What could help is the elevated THPO, and what happened in this patient, and it is after MPL receptor binding, there is an internalization, proteasome degradation, and basal expression of a receptor on the surface. So when you have few megakaryocyte plaquettes, TPO level increase to compensate through receptor and so on. And this is a good sign in this patient. And some mouse model have been developed to explain the mechanism of aplasia. And mice MPL and THPO knockout have the same phenotype. They show a progenitor reduction and the attrition in cerebral transplantation in mice, which could be explained by a very interesting defect of HSCs. And the long-term HSC seems to be the most affected cells with a high MPL expression as they regulate quiescence, and they can be also responsible for leukemic initiation, even if we don't think there is a lot of leukemic risk in this population. So coming back to Rose, just briefly, I explained the case. So we perform a TPO dosage who was very elevated. We show that she has few MPL expression, cell surface by flow. And in fact, we went to bone marrow. We saw bone marrow dysplasia and moderate dysmegakaryopoiesis. Bone marrow biopsy was performed, but it didn't give us a lot of information more about the bone marrow itself. So it was consistent with a count. And in fact, we were able to identify two mutations in PL. It was a compound heterozygosy. The first one, the missense variant R102P, was identified in 7th family. It was difficult in vitro to see if it is a defect in receptor expression or signal transduction, and in vivo it was never studied. It was reported as a homozygous or compound heterozygous in the literature. And the second one, missense variant, was in the cytoplasmic domain. It was already described in a child of 22 months as compound heterozygous and shows severe thrombocytopenia, and the CMPL was not expressed and elevated TPO. So in the lab, we were interested in, and what we show is that in the MFI of MPL expression by flow cytometry was in rows here. The patient was half of a healthy donor, and the mother has more or less the same as a healthy donor, and the father has half as well. So it was interesting to study how was the receptor expression. And when we try to study our MPL activation was done on patient platelets by different agonists. So we show with human TPO, romiprosting, and L-thrombopag by phosphofluorocarbon on flow cytometry. So in the panel A, it was the diagram showing the workflow, and in panel B, in our patient, you can see in the middle that some agonists such as L-thrombopag could activate some pathway involved in megakaryocytic development. As you can see, romiprosting is less efficient, so it was interesting if you want to test it in clinics and to use in this patient to see what she was partially responding to this TPO array. So for two others, siblings, Nathan and Haggett, we performed bone marrow aspiration at 6 and 8 years old. What you can see, and it's interesting to share, is that we can have, as in Haggett, normal bone marrow, normal megakaryocytic karyotype. In Nathan, you have a megakaryocytic hypoplasia, but the cellularity, the global cellularity was normal. So sometimes you can have more or less normal bone marrow, so it's not a sign. The only sign is if you think to count. And you can see also that the TPO dosage was in normal range in the two patients. So when we went to genetics, we could identify in these two patients two heterozygous variants of MPL, as in Rose, but with a moderate phenotype. So we identified the first one in intron 3. A variant was referred as pathogenic, and analysis in the mimigene system show that it alters significantly the splicing of exon 3. And the second one was inherited from the father, and the parents were not related. It was predicted as pathogenic, even if it was not described before, and look at it in the cytokine receptor domain, and I'll show you it is a very hot spot in this disease. So this is consistent with CAMT, with moderate phenotype. I will go at the end of this genetic part to the CAMT-THPO. It is very, very rare disease. It is linked to a mutation of THPO. Usually the THPO dosage is obviously low in the sera. It's like a kind of IBMS phenotype, and it is a phenotype which is similar to CAMP-MPL, sometimes with late onset thrombocytopenia, and there are no reports of leukemic transformation so far. So be aware, because this condition is not treatable with HCCT, it is not a curative treatment, and could respond to TPO array in the 3 myeloid lineage, even when they get pancytopenia. So it's a really good option for this patient, even if we don't know if we can leave patient under TPO array for life. It is a good option. And be careful sometimes, even testing THPO several level by ELISA assays cannot provide final certainty in the treatment decision. And you can detect THPO, but it is not a THPO which can activate the receptor. So at the end, I will say a word, if I have 5 minutes more, about evolution and treatment. So before HSCT, before bone marrow transplant, all these patients had a poor prognosis, and the evolution to aplastic anemia in the first years of life was really life-threatening in the first year publication. So I think there is an underestimation of the disease, as I show you as Nathan and Agathe case. There are some patients which could have a mild thrombocytopenia and they never got genetics, so we don't know their account. So maybe there's a kind of underestimation. There are some milder form, not so severe, but when intracranial hemorrhage arrived in patient, it is a very, very life-threatening condition and gave some morbidity. So the leukemic risk is probably low. There is one description at the beginning with BLL at in a 3-month boy. The MPL mutation seems to be located in exon 1, but it is not paper and cannot, there is no other description of leukemia. There are some initial reports of GMML, of SMD, but without genetic testing, though, so we cannot rule out this is count or not. And the clonal evolution is very difficult to assess. Sometimes before bone marrow transplant, there is a description of monocytosis of T8 in bone marrow aspiration in patients. So the evolution and treatment. So patients will need some platelet transfusion. Obviously, if we can avoid immunization with glucoside depleted product, it's better. We can use antifibrinolytic for minor mucosal bleeding. What is not useful in this condition is steroids, IGIV, androgens, splenectomy. That's why it's so important to have a genetic diagnosis. Be careful, some patients that could respond they could have a transient response to IGIV, usually when they're really young. There are some description of that. And the HSCT is the only curative treatment. There were a lot of mortality before HSCT in early description, but not so high now. The TPO arrays could be used in CANT THPO in some MPL mutation. I will show you in a minute. And gene therapy was described, but the restoration of MPL receptor is very difficult. There are a kind of thrombosis in early phase of development, and it is not available for patients at present time. So bone marrow transplant was first done in 1995, first described, not done maybe. And there is a French series published by Jean Dahl in 2014 of 63 patients, most of them because it is the first indication underway transplantation with siblings or matched unrelated donor. There are some mismatched unrelated donor and some matched over relatives. So cord blood was used in 11 cases, and it's mostly myeloablative conditioning. What we could see in this series is that got not a very high GVHD disease. The survival rate at 5 years was 77%, with a TRM toxicity-related mortality of 13%. Main deaths were linked to the procedure, and the main problem was a resection, and because 11 patients underwent a second BMT and 6 the third BMT, and most of the deaths were in this cohort of patients. So there is a small series of 5 people, 5 patients treated with cord blood, with encouraging results, with good chimerism. Not a lot of GVHD, but it is only 5 patients, 5 children. So the last publication on and the most recent one on BMT show an important thing. What we knew from the beginning, but confirm it, that the mortality is higher when we have a mismatched relative or a mismatched unrelated donor after for HSCT. which is compared to a matched sibling or matched unrelated donor. So we should search for that and balance the indication of bone marrow transplant for this patient in front of a donor. And they confirmed that the 1 year incidence of breast failure was elevated in this population, around 20% after mismatch HSCT compared to 7% after match HSCT, which is not significant, but could be taken into account if we have more patients, maybe. There are some remaining questions. One is the best timing as transfusion sparing for this patient. The donor choice, I've just pointed out this point. Conditioning is usually myeloablative in this condition, but some reduced intensity conditioning have been used in second or third transplant. And obviously there is a toxicity of a second or third bone marrow transplant. So just to show you that some CANT MPL patients, they can also respond to TPO array. They're expected to be insensitive to TPO and TPO array because there is a mutation in the receptor, but some could be rescued by TPO array, as you can see in the bottom part. So, for example, we have a look to the mutation, missense mutation F104S, mutation in cytology receptor membrane 1. You can see here that this peptide, which mimic thrombopag, could rescue partially the activation of the CNPL receptor. So this could be interesting as a bridge to transplant or for some patient with bleeding, and could be interesting to test in patients. So as a take-home message, and I will stop after that, I will just summarize the 4 major points. So CAMT is an inherited, rare inherited bone marrow failure syndrome, which is presented as isolated thrombocytopenia. So as a pediatrician involved in hematology, we need to be aware, and thrombocytopenia at birth could progress to pancytopenia due to the exhaustion of progenitors. There are higher variability of clinical course. I example 2 in this webinar, and this could be from asymptomatic thrombocytopenia to very severe bleeding. Since maybe all of them, CAMT1 MPL in the majority develop a fatal bone marrow failure, which will require CHCT. All patients for me who had a kind of Amegakaryocytic thrombocytopenia should be tested for MPL mutation. That's in prior bone marrow assessments first. And if a molecular confirmation of CAMT is not possible, if it failed, maybe you should consider if your child with IBMF has a CAMT or not, and you should exclude patients in which HSCT is not an option, for example, thrombopoietin production defect, or which another transplantation regimen, like another conditioning, is needed, for example, some fanconi or diamond black vanillin. And I will finish here. I will many thanks to all of you for your attention. I will be happy to take some questions.
Thank you very much, Professor Pasquet, for your presentation. So indeed, now there is unique occasion for asking directly to the experts some questions, if any. So yes, so there is one. I will, oh, sorry.
From Paul.
Yes, I can read it.
Okay.
Yes, thank you. Sorry, I just missed the chat for 1 second. So thank you for this wonderful talk, Marlène. What do you think are the most difficult differential diagnoses and how to rule them out? Also, thank you to the saying to test TPO-RA even in the presence of MPL mutation.
Okay, thank you, Paul. I think in the case you have a 3 lineage IBMF, it's very difficult if you don't have a thrombocytopenia first, if you don't have a story of a patient, it's difficult to make differential diagnosis. And I think you need some powerful genetics like genome analysis or so on, or NGS first, diagnostic NGS, then genome analysis, because it's difficult. At the time you have thrombocytopenia first and you can follow the patient, I think it is easy to differentiate. I think the most important thing is to rule out some MECOM-associated syndrome, and I reported it that sometimes it's difficult, and some OXA11 or the citrus conditions, so you can usually detect with some X-ray. And I think the other condition of IBMF, you can have Fanconi anemia, you have dysmorphic features. In this keratosis, you could be helped by the telomere length. So I think at the beginning, you have to do a very good screening to rule out all the other IBMF. If you have a truly large aplastic anemia. So for this test, I will recommend to test TP-ORI for the second question, even if you have impaired mutation, because if you can save, for example, the two siblings I explain the cases, they have to go under surgery, so we were happy to know if they could respond to a thrombopag or not. So I think it is important, and this could be helpful to save transfusion.
Thank you very much.
Okay, Paul has a second question. Yes, engraftment failure is...
Yes, sorry, we used to read them, because then when we
Okay, sorry.
So no, you could not know. Engraftment failure is a real issue in this disease. Are there known risk factors for engraftment failure, type of variant, conditioning, age at HCST? Thank you.
It's a very good question. I don't think we have yet the answer. I think conditioning, because when reconditioning is used, it is there are less engraftment, but there are so few reports, so it's very difficult to conclude. And the type of variant I didn't read in all the literature I had, but maybe I missed it. I didn't read that the type of variant is associated with, and there are no issue with the age as HSCT. I think it is more or less the condition, and as there is an intrinsic defect of HSCs and progenitor, I think this is responsible for this kind of poor engraftment, like we can see in other IBMF, but it is not the case for all. So maybe there are some more information to discover on this disease, why there is a poor engraftment. But I think maybe the conditioning is the most important point.
Thank you. So maybe waiting if we receive other question. I will just advertise the next session, because as said, this is a comprehensive program. So the next one will be on the 5th of June. With us, there will be Paolo Gressele, and we are going to talk constitutional thrombocytopenia and bleeding risk. So just to say, so we have received one comment. Thank you for the interesting talk.
I would say thank you for inviting me, because it is not the kind, I think, of it is not what you are used to, because it's more IBMF field. But I think it is interesting to know and to notice that there are some conditions that could prevail with only thrombocytopenia, and to know what happened and what to do at this time.
Thank you. Okay, so, well, I think we can close the session. So thank you very much, Professor Pasquet, for having shared with us your expertise. I also would like to thank the audience for being here with us. So hope to see you soon for the next session. Thank you very much.